Hello and welcome back to the afternoon keynote and also the last keynote of PyCon Sweden 2020. I'm very excited to introduce to you Lucie Gatpai, who is the head of data science at Uppsala Monitoring Center, and her team's goal is to improve patient safety. So she will tell us more about that now. Lucie will also be in the chat. And in the end, we will have the usual question and answer session. So everybody, please welcome with me, Lucie. And I'm very curious about your talk.
Thank you, Christine. So yeah, I recorded this entire talk, but I will be available for questions. So both in the chat during the talk, but also at the end. So let's go. Hi, everybody, and welcome to this keynote presentation entitled Detecting the Unexpected, Monitoring Medicinal Products to Improve Patient Safety Worldwide. We live in truly unprecedented times. During 2020, the coronavirus swept in all our societies in just a few months, with a cumulative total number of confirmed cases of more than 50 million. And by the look of it, at the time where I'm recording this presentation, it is here to stay with us for a while more. We still have many new cases discovered daily, and sadly, still many deaths happening every day. So the battle is not yet won. But there is some hope. Pharmaceutical companies are racing to research effective vaccines against the virus. Quite a few of these vaccines have gone a long way in different clinical trials and could be now around the corner for use in populations. As the saying goes, time is of the essence. Considering the pandemic emergency, regulatory agencies might allow for accelerated approval procedures for these vaccines once their effectiveness is sufficiently established. And if so, this will have important consequences. Evidence of the safety profile of the vaccines might be weaker than usual. Therefore, continuously monitoring the safety of those vaccines once they are released on the market will be of the utmost importance. And this is exactly what the Uppsala Monitoring Center has a long experience of doing. My name is Lucie Gatpai, and I am head of data science at the Uppsala Monitoring Center. I have an engineering degree in computer science and applied mathematics. I did a master in mathematical modeling for medicine and biology, and I did a PhD in population genetics at Uppsala University. After that, I got a position as a data scientist at the Uppsala Monitoring Center in 2016, and I never left since. In the beginning of the year, I became manager of the data science team, and since September, I am now head of data science. I have been using R a lot in my PhD studies, but upon entering the realm of data science, I've discovered Python. I loved it and never looked back. So I am particularly happy to be here today in front of the Python community to have a chance to give you a little peek into some of the recent method development research my team accomplished for improving our ability to detect safety issues of medicines as quickly and reliably as possible. I would like to stress that most of the work I will show you now has been implemented in Python, using various libraries that I tried to mention. I won't show you any code or go into really technical details, but you will get an idea of what it is possible to do in our context with Python at the core of our data science tools and research. So Python is really cool. It's a versatile language, and we are truly indebted to all the Python packages developer out there to make the bleeding edge of data science method accessible to so many others. So kudos to all of you. Now, before I dig into the research, I would like to tell you a little bit more about the Uppsala Monitoring Center and the core of our activities, which is pharmacovigilance. This entire field was born out of a tragedy in the late 50s and the 60s involving this drug, thalidomide. Among different uses, this drug had gained popularity with pregnant women to treat morning sickness. But physicians and scientists in different parts of the world started to question the safety of this medicine as they noticed a clear increase in babies born with congenital anomalies, the most common one being phocomelia, where the baby is born with much shorter limbs than normal. Upon investigation, the association was so clear that the drug was withdrawn from the market. This tragedy revealed the need to monitor medicines throughout their life cycle to continuously evaluate their benefit-risk balance. This benefit-risk balance is not constant over time. You cannot just assess it and you're done. Evidence of the safety profile of medicines change over time. New safety issues might be discovered. Risk factors might be identified. Or newer and possibly safer medicines might be released on the market. So we need a system to do this monitoring, some place to gather evidence of the potential harms caused by medicines. At the time of the thalidomide tragedy in the early 60s, there was no such system. So the WHO decided to launch a multinational initiative called the Program for International Drug Monitoring. 10 countries were participating originally, and Sweden was one of them. The aim of the program was to collect and share cases of suspected side effects into one common database, which is now called VGBase. At the start, the operations of the Program for International Drug Monitoring were held in the WHO headquarters, but after a successful pilot period of the program, the operations moved to Sweden, in Uppsala, in what later became the Uppsala Monitoring Center. So it started with 10 countries only, but today there are more than 140 countries participating in the WHO Program for International Drug Monitoring, and VGBase, which we maintain and continuously analyze, contains around 23 million reports of suspected side effects of medicines from all over the world. So we have this important data, this large collection of cases of suspected side effects. How do we go about and detect safety issues related to medicines? Well, first, let's have a look at the data itself. As I mentioned before, VGBase is a collection of case reports of suspected side effects of medicines. On each report, we may find different kinds of information. The most basic information we find is the patient age, the patient's sex, the country who reported the case, the reactions the patient experienced, and the drugs the patient was on, with a flag indicating the suspicion of the reporter regarding potential causality. For the purpose of analysis, these reactions are all mapped into a terminology, in this case, MEDRA. I mention this because it is important for the research I will show you later. The terminology is used to facilitate analysis so that we treat medical conditions, which sometimes can be described in different ways, into single concepts For example, fainting or passing out are two expressions that can be represented by the single medical term syncope. So now, each combination of a given drug and a given reaction could be representing an actual safety issue, or it could be noise. Today, VGBase have 3.5 million possible combinations of drugs and side effects that could represent a safety issue. Many of them are already known and are listed in those little pieces of paper that you find in the packages of medicines, which I hope you all read very carefully, of course. But some of those safety issues are still emerging. Like the trend is there, but the evidence is still weak. These are the ones that we are after, the not yet identified safety issues. Traditionally, this is how pharmacovigilance has been done, by following trends of reporting for combinations of one drug and one suspected reaction at a time. For each drug and reaction combination, you compute this contingency table. If the drug and the reaction are reported together by chance, you would expect the number of reports with both to be proportional to the number of reports with the drug, A plus B, and the number of reports with the reaction, A plus C. In pharmacovigilance, this is called disproportionality analysis. And a classic way to measure disproportionality is to compute the ratio between the observed number of reports having both your drug and reaction of interest divided by the number you would expect if there is no association between the drug and the reaction based on the frequencies of those two in the entire database of reports. This is very helpful because now you can rank your 3.5 million possible drug reaction combinations and bring on top those that have many more reports than what you would expect by chance, revealing combinations that are more likely to represent real associations. This approach has been used for decades now in pharmacovigilance, but it can be simplifying the problem too much because behind all of this, there are patients, human bodies experiencing side effects, and those side effects are in many cases complex clinical manifestations. So reducing them to single concepts that you assess separately makes it much harder to see the bigger picture. A single term might get an entirely different interpretation depending on context. Let's take vomiting, for example. Imagine these two different cases. On the first case, the patient experienced vomiting with abdominal pain and diarrhea. On the second case, the patient experienced vomiting with headache and abnormal vision. It is clear that in the first case, the patient experienced the side effect of gastrointestinal nature, while the second patient most likely experienced a strong migraine. You would not like to just look at how a given drug is likely to have caused a given reaction term, like vomiting in this case, but how a drug is likely to have caused a given clinical picture, set of terms that together describe how the patient reacted to the drug. So to do this, UMC has developed a new approach, at least new in the pharmacovigilance field. Instead of considering single reaction terms for assessing the safety profile of a drug of interest, we look at the entire set of case reports for that drug, and we cluster the reports based on all the reaction terms they contain. By summarizing the distribution of reaction terms found on the reports of these clusters, we can hopefully build a clinical picture that makes sense. This task is akin to topic modeling in a collection of documents. The words would be the reaction terms and the documents would be the reports. So how do we do this? We use a latent class clustering algorithm based on the mixture model. We start by randomly allocating the reports to a number of classes. Based on the number of reports in each class, we can estimate the marginal probability of belonging to the class. So for the blue class, we have 6 reports out of 25. And we also estimate the probability of observing each single reaction term from the terminology within each single class by counting how many times a given term appears on the reports of the class. Then we can use the probability of each class and each term within each class to compute the class of highest probability for each report and reassign the reports accordingly. We repeat this procedure, following basically an expectation maximization procedure until convergence. And as we know that the expectation maximization algorithm converges to local maxima, not necessarily the global one, we repeat this process for many different random starts, and using the wisdom of the crowd, we build a consensus clustering based on how often reports have been placed together in these different runs of the algorithm. This entire algorithm has been originally developed in MATLAB, but we decided to re-implement everything in Python after a while, as it gave us more modularity and versatility. To use the clustering algorithm even more easily, we even developed a Dash interface. This slide that I've shown you earlier is actually the result of the algorithm on a real example. The drug of interest in this case was the Hpv vaccine, a vaccine against the human papillomavirus, which has been associated with cervical cancer in some clinical studies. The 4 biggest clusters obtained paint indeed 4 different clinical pictures, which was assessed and recognized by one of our medical doctors. The first cluster apparently represents systemic reactions that are expected from a vaccination. It contains terms like headache, nausea, pyrexia, which means fever, and dizziness. The second cluster relates to allergic reactions to the vaccine, and we find terms like pruritus, which means itching, rash, erythema, which means redness of the skin, etc. The third cluster relates to vasovagal reactions, when you feel like you're about to faint or you actually do. The fourth cluster depicts local reactions to the injection of the vaccine. You can actually read about the result of this study in this open access article. Another paper is under review, which describes the method fully. And finally, there is a master thesis published this year which describes technical and methodological improvements to the algorithm. So, by grouping terms thanks to the clustering algorithm, we now have a way to understand better the entire profile of possible clinical manifestation to a given drug. This has been seen as very useful for our pharmacovigilance experts assessing specific drugs of interest. Now, one drawback of the method is that, for now at least, we need those experts to look at the clusters and interpret the picture they paint. We can't do that automatically. We also need to develop a new quantitative framework to assess the probability of a given cluster to represent an emerging safety issue. This is a complex research question that I believe will lead to exciting novel methods in the future. And finally, another limitation of this clustering algorithm is its dependence on the exact reaction terms. So what do I mean by that? As I mentioned before, All these reaction terms are taken from a list of terms defined by the terminology used on the case reports, the MEDRA dictionary. Using these discrete entities, one has to make a choice in how to describe the reactions the patient experiences, and that choice will affect the probability of the reports to belong to the different clusters. Let me give you a few concrete examples. The MEDRA dictionary has a term for hypertension and a term for blood pressure increase. It has a term for myocardial infarction and a term for acute myocardial infarction. Now, people doing the data entry to produce the case report, they are likely to choose one term or the other, not both. So if case report A contains hypertension and myocardial infarction, and case report B contains blood pressure increased and acute myocardial infarction, they are much less likely to be placed in the same cluster, although they do depict a very similar clinical picture. So how could we integrate somehow similarity among different terms? The good news is UMC has developed yet another approach, new at least in the pharmacovigilance field, to compute similarity within the MEDRA dictionary in a totally data-driven way. Instead of representing the reaction terms as discrete entries from the MEDRA dictionary, we wanted to compute a space. A space where each term would be represented by a dense vector whose coordinates would carry meaning about the term itself. In that space, similar or related terms would be close to one another. Now, this problem will sound very familiar to some of you because this very same problem is found in the natural language processing field. Instead of MEDRA, we have a vocabulary, for example, the entire English dictionary, and the aim in this context is to find good representations of words in the vocabulary, representations that are meaning aware. To answer this problem in NLP, distributional semantic methods have been proposed. Most of the existing methods are data-driven and use very large text corpora. They are trained in an unsupervised manner, which makes them very desirable, and they are based on co-occurrence patterns of words within context windows, using a principle that is well described in this famous quote by John Rupert Firth, an English linguist from the 50s. "You shall know a word by the company it keeps." So in other words, you, and more interestingly, the machine, can understand the meaning of the word by looking at what kind of context the word is found in. The most widely used distributional semantic methods today are Word2Vec, developed at Google, and GloVe, developed at Stanford. So we decided to use Word2Vec. The way Word2Vec works is essentially as follows. You look at every word within a context window. In the CBAO implementation, you try to predict the center word from the context words. You model every word by a vector of arbitrary but fixed dimension. So here, the vector omega for the center word and the vector c and c prime for the context words. Then you use those vector representations to model the probability of observing the center word given the context words using the softmax function on the representation. And then you learn the vector coordinates with stochastic gradient descent or another gradient descent-based procedure to maximize the log likelihood over all words in the corpus. When computational power became good enough to handle their computation in the early 2010s, Dense representations of words obtained with distributional semantic methods like word2vec have led to tremendous improvements in performance of machine learning models for all kinds of NLP tasks. So there seems to be great advantage to move from discrete representations of words to dense, continuous ones. So we thought, hey, why not trying it out in our context? Because after all, like a sentence is a collection of words, a case report is a collection of drugs and reaction terms, and therefore can provide a sense of context. Turning case reports into sequences of randomly ordered drugs and reaction terms, we could apply word2vec and let the algorithm learn something about the drugs and the reactions from patterns of co-reporting using VGBase as our entire corpus. And it worked surprisingly well. For illustration, here's the list of the top 10 neighbors to hypertension. I actually made an interface to browse this space, but I won't show it to you because it is made in R Shiny, and I guess it would be bad manner to show some R at a Python conference, I guess. But anyway, so as you can see, the algorithm successfully recognized that blood pressure increased was a related term to hypertension. And same thing if we look at myocardial infarction. The algorithm placed it close to acute myocardial infarction as well as other very related cardiovascular issues. So remember that all we used were co-reporting patterns in VGBase. The word2vec algorithm in this case did not know that, for example, myocardial infarction and acute myocardial infarction shared words and thus had a higher chance of being similar. In fact, all terms in the terminology were actually converted into integer IDs before being fed to the algorithm. So truly, no human-derived semantic information was given to the algorithm. I find it absolutely mind-blowing to think that in the way people report terms together in how they describe side effects, it allows a picture to emerge about their intrinsic meaning. And that, in my opinion, is pretty amazing. So you can read more about this work in this paper published about 1 year ago. The method's been developed also in Python using the gensim package for word2vec. And it took about 3 days between the original ID and a working implementation of the space, which goes to show the amazing power Python has, especially thanks to its open source nature and the massive number of developers contributing to make the most recent advances in data science available to all. Again, kudos to you guys out there. So, how can we use these new representations? As I see it, their main advantage lies in their ability to give us access to continuous measures of relatedness between any pair of terms within the terminology. So if we go back to the example I showed before as an example of the limitation to the clustering algorithm, if we were to use vector representations for the terms, we would be able to conclude that because hypertension and blood pressure increase are close to one another in the vector space, and because myocardial infarction and acute myocardial infarction are close to one another as well, these two case reports could be considered similar. So now we have a way to separate terms that are the same but mean different things, thanks to the clustering algorithm. And we also have a way to group terms that are different but mean similar things, thanks to the vector representations. I believe that combining these two approaches together will most likely boost our ability to create these clusters of case reports that paint these distinct clinical pictures about side effects. How to best do that integration of both approaches together is not yet figured out, so I'm expecting exciting research to be done in that area. All right, so what we're proposing now is a new way to look at our data. Instead of going for those drug reaction combinations, as we've been doing for decades in pharmacovigilance, we could mine for clusters of reports that could be indicating of emerging safety issues. As I said earlier, we will need to develop a totally new quantitative framework to guide our search through the possibly millions of clusters that this combined method would give us in hunt for those emerging safety issues. However, regardless of the method, if we want to find unexpected, previously unknown safety issues, well, we need to know what's the current state of knowledge about the side effects medicines can cause. Unfortunately, there is no universal reference that is listing all the possible drugs and all the known side effects they can cause, nicely mapped to our favorite terminology, the MedRat dictionary. In each country, regulatory agencies like the FDA in the US or Läkemedelsverket in Sweden are requiring all marketed medicinal products to have a reference document, often called the product label. This reference document, the label, lists many things regarding the medicinal product, like what it contains, what it is indicated for, when it shouldn't be used, the kind of patient this product can be used on, the posology of the product, its effects on pregnancy and lactation, etc. Basically, lots of important information about the medicinal product, including its known side effects. Unfortunately, this is free text, and unfortunately, in most countries, it is not possible to download in electronic format the entire set of those documents. But fortunately, though, the FDA compiled their product labels in one database called DailyMed and made them available for download. So here's the website with the download links. So we have downloaded a big bulk of the US product labels and developed a pipeline to continuously update the data with the latest changes and apply a text mining algorithm to extract the known side effects on thousands of products marketed in the US and map all these side effects expressions to our terminology of choice, the MedRat dictionary. We've been using Apache Airflow to handle the pipeline, which we have found very useful and easy to handle. This is an example of a product label, in particular, an extract of the adverse events section of Gardasil 9, an Hpv vaccine. Do you remember the clusters we found in the study on the Hpv vaccine side effect reports? So here we see two of those clusters represented in the table, which would then be considered as already known: the expected local reactions and the expected systemic reactions, which is actually quite reassuring about our clustering method. Anyway, as you can see, safety information can be found in table form, like this, but also in free text form, like in the example shown here. Regardless of the form, the task here is to first recognize the mentions of side effects, so basically a named entity recognition task, and second, to map the extracted mentions to the MedRat dictionary, so basically a normalization task. Conveniently, we have been able to use training data annotated by the FDA because the FDA held the challenge on this task in the beginning of this year. We had 100 fully annotated product labels under the form of XML files like this truncated one on the slide. For the normalization task, we also used our own data, VGBase, to expand examples of mappings to MedDRA in our training set. For the named entity recognition, we used an LSTM model combined with a CRF, and for the normalization, we used a BERT model. All of this was done in Python as well, using PyTorch, LNNLP, and transformers from Hugging Face. There are different kinds of complexities associated with this data. For example, overlapping mentions and discontinuous mentions, which we have not all addressed. But overall, the mining and mapping algorithm is quite performant, with an F-score of around 0.82 for the named entity recognition part of the task, and an F-score of 0.6 for the normalization part of the task, which is a pretty decent score, actually, considering that this is a highly multi-class problem with around 20,000 different possible terms to choose from. If you're interested in this work, you can check it out in this master thesis, which was published this year as well. So, thanks to our text mining algorithm, we have now started to create what we wanted in the first place. A reference which lists known side effects for many medicinal products and have them mapped to MedDRA. It does not have the universality that we would hope for, since it's created from US data only. But most of the products marketed in the US are marketed elsewhere, and many regulatory agencies in the world are keeping up to date with US label changes. So, in general, information found on products in other countries is very similar to the information found on US labels. So we are now finally arriving at the dusk of this presentation. If you keep anything with you, I hope it will be the following points. Monitoring the safety of medicines is very important, and it will be crucial for the upcoming COVID-19 vaccines. UMC, on the behalf of WHO, is maintaining and analyzing VGBase, a database containing 23 million reports of side effects from more than 140 different countries, and that although traditionally pharmacovigilance has relied on disproportionality analysis to mine for novel safety issues in large databases, this method can be simplifying too much in some cases because it ignores the complex nature of side effects. We have developed a clustering algorithm that can reveal clinical pictures in sets of reports and can disambiguate reaction terms, recognizing that two same terms might have different meanings based on the context. We also have developed vector representations, which allow us to compute similarity between terms and therefore combine together meaningfully reactions that were described differently. We have developed a text mining pipeline to extract known side effects from DailyMed. Those three approaches combined, together with a quantitative framework to score clusters for true associations to drugs, I believe will provide a truly powerful way to mine our data for the unexpected, not yet recognized safety issues. I'd like to stress out that all this data mining and automation will never be able to replace the expertise of seasoned pharmacovigilance assessors who can apply the clinical reasoning necessary to understand the picture described by the data and figure out the nature of the potential safety issues found. The usefulness and effectiveness of our work are deeply rooted in the multidisciplinary collaboration with people of many different backgrounds: pharmacists, medical doctors, educators, communicators, developers, etc. So our role as data scientists is to facilitate their work by bringing forth interesting patterns in the data, combine different but relevant data sources together, and integrate in our data mining methods the best data science has to offer. Now, inspiration can come from anywhere, like in the case of the vectors representations, where we suddenly drew a parallel between our problem and a similar problem in NLP. So my advice to you is to keep your eyes open. I mean, read that archive paper that just got you curious, or go to that odd presentation that sounded irrelevant but fun. I mean, to misquote Einstein, I would say two things are infinite: the universe and data science. And I'm not sure about the universe. Thank you very much for watching this talk. Now, remember to keep to the recommendations and keep safe in these COVID-19 times. And because we're all patients, I will leave you with a little song we produced to raise awareness on the importance of reporting side effects. Thank you all, and see you around virtually.
When you get an A, there's a pill you can take. But if it makes you unwell, remember that you need to tell. Take and tell. Take and tell. Side effects show that your doctor knows. Take and tell. When you take your meds, there might be side effects. Remember that if you get some, or even if you just get one, you gotta take and tell. Yeah, take and tell. That's what you gotta do. If side effects show that your doctor knows, take and tell.
Thank you for this fantastic presentation, Lucie. Very, very inspiring to see how our patient lives get much safer with your work. So I really enjoyed it a lot, and I also learned a lot. So let's see if we have any questions from the audience. So I got one here from Stephen. Can the post-market cluster analysis be correlated to the data collected during the trial before release and contribute to improve the process of future trial? A long question.
Yes, it's a good question, but it's a bit tricky because we don't have the data. But the method is published. If we could actually provide the pharmaceutical companies with a nice tool to apply it, maybe they will be able to do it on their own data during their clinical trials. So we UMC cannot do that, but maybe each pharmaceutical company could do it if they were be given the right tool. Yeah.
All right, thank you. Then we have a question from Alexander. You said that you have historically been using R. Is there anything you wish that Python had which R got?
Yeah. I mean, everybody experienced the language a bit differently, but I know that I got very frustrated with extracting data from pandas. Mm-hmm. It's like you got to have these .loc or .iloc, and I don't know. I find it a bit complex. While R is very, very straightforward to slice and dice your data frames. It's very easy. Now R is very well made for all the statistical analysis and the math stuff. And I think it's much more used in an academic setting. So when it comes to like novel models that are more of mathematical nature, you're more likely to find an R package maybe than a Python package. I can be wrong, of course. I don't know, but when it comes to data science, I found that the contrary is actually true. And now I've been working a lot with NLP and text mining and everything, and these machine learning models like the transformers, which are quite advanced architectures. You have very, very nice Python packages that are being released like as soon as a paper come out. Like, I don't know who's doing that work, but they just like, it's all like people start to code and put it out. It's so fantastic. I find it absolutely amazing. But yeah, something that R has, and I wish Python. I like R Shiny. I've tried the Dask, and I cannot make it as like and pretty in just a few lines. But yeah, that's my answer.
Yeah, I hope that both languages have pros and cons, and I hope that there's also a way to combine them in the future. So let's have a look here. And in the HPV example, how did you get the initial 4 or 5 clustering groups? Did you use the unsupervised machine learning or the already existed hierarchy dictionary?
Thank you, Bulin, for this question. It's actually funny because Bulin is a master student in my team. So yeah. Yes. So it is indeed an unsupervised method, as I described. We used this latent class clustering algorithm, which we start with a random grouping of those reports, and then by learning the parameters back and forth and reassigning, we eventually converge to something, and then we do consensus clustering because it was very dependent on the initial clusters that were put. So yeah.
I hope that answers your question, Bulin.
But for him, it's easy. He can always ask me more on Monday.
But we can take his next question also. Could you please explain more about how did people get the consensus clustering from clusters?
Yes, so we've used so we look at all these runs of the actual maximization algorithm, and then we take all possible pairs of reports, and we check how many times did they end up in the same cluster, and if we have a threshold. I think in this case it's like 80%. If in 80% of the cases they are in the same cluster across all these runs, then they will be put in a same cluster at the end of during the consensus clustering. And we use a single link, so we do all these pairwise checks of whether or not they should be put together, which makes then a graph. And then we have actually 2 approaches. So you can have the single link approach or community detection. But we're exploring which is best. It's not easy because there is no gold standard. There is no truth in this case. Do they make sense, these clusters that we we build, or don't they? So the evaluation of the method itself is actually a quite challenging thing to do, and requires quite a bit of that medical expertise that thankfully we have in-house. So very nice.
If I'm allowed to ask a follow-up question about that, I was wondering, you were mentioned expectation maximization algorithm has to run several times. So how do you define how often it needs to, like, how many parallel runs do you have?
Yeah, I think we have. It's been a bit of rule of thumb. We start, I think it's like about 100 runs, but it's not been a completely. It's a bit. We tried. It seemed to be kind of good. So
I guess there's also no straight number one can put on that.
I guess if we would have noticed that the clusters obtained were extremely similar on a few cases, then we would not need to go for that much diversity. But you can have like thousands of reports to cluster, so of course there will be some noise associated with it. And some reports have many reaction terms, and some have just a few. So that's also influences the result of the algorithm. Yeah.
All right. Any more questions from the audience? I have a bunch more. I really enjoyed your talk.
Let's see what the audience says there.
So while we're waiting, I'm just throwing that one in. So you were mentioning that you were using Word2Vec at some point. Did you have time to reevaluate old reports and saw a difference there?
I'm sorry. What do you mean?
Like in the old reports that UMC did, I guess you were using some kind of model, and when you were using Word2Vec, did you see a difference in the results of the reports?
Okay, so we've actually used the entire VG base. The difference that the vectors are giving us, but using this Word2Vec to actually produce these two representations of the reaction terms, and even the drugs. Actually, I haven't talked so much about that, but so in a sense, you could start to build also a new representation of the reports. We haven't gotten there though, because now, so we know a report is a collection of terms and drugs, and we have a vector for each and one of those, but how to meaningfully combine them together and build a new report space instead of just a term and drug space is actually not fully elucidated. We could apply, let's say, an average or some kind of aggregate function, but I think that would not be successful. So now we're still working with the report as they are, what I think you refer to as the old reports. What we do though is that we can still compute like maybe distances between reports, seeing like, okay, this report has all these terms and that one has all these terms. Can we find like the closest neighbor to each and one of these terms and compute a sort of distance between two given reports? And maybe do clustering, actually. I mean, might, using the vectors, do a purely vector-based clustering. And so much research that can be done.
Thank you for taking the time. So let's see. Yeah, I had a general question as well. So you're head of data science at Uppsala Monitoring Center. What would you advise people that want to pursue a career in data science say? Like what to focus more on? Is it like the domain knowledge, the tools? Like what to look out for?
Yeah, it's my little humble opinion. I really feel like well, domain knowledge is very important to gain, because you cannot get to the ideas that matter if you do not understand so who you are doing it for, like what's the actual need that you're trying to address. But data science is also a very fast evolving field. I mean, I don't even know if it's a field. It's like composed with so many areas.
Yeah.
And I do not believe everybody can follow everything at once. But let's say you have your niche of interest within this very large landscape. I believe you also need to really keep an eye out on what's coming, because a lot of stuff is coming out. And now watching all these talks about Python, and I realized, like, even just the Python language, I am not up to date at all. Like, I was feeling, oh my God, F strings. I don't even know what an F string is. I've never, like, I was probably still in my head being Python 3.4 or something. So keeping up to date is quite the challenge, but it's an important thing to do. Yeah. So both domain knowledge and keeping your tools sharp.
Great, thank you. Yeah, the F strings, Alexander. Great presentation.
Yes. Oh my God, I know nothing.
Yeah, but now we know. Now we will only use them in the future.
Exactly.
All right, then time to wrap up. Thank you again, Lucie, for your presentation and for taking the time. And for the rest of the people that are still attending the conference, even though it's a Friday afternoon, we will branch out again. We have a panel discussion coming up, and there are also some lightning talks. And we will meet each other on the main track at 7:30 to wrap things up. So have a nice rest of PyCon.
Thank you all.
Hej då.